Yes, sir. Sir, we are live now. It's changing also, sir. The slides are changing.
Okay,
Sir,
okay,
we are
okay,
live now. I request
okay.
your permission to start with the session, sir.
Yeah, sure.
Thank you. Thank you, sir. Hurry home, everyone. A warm welcome to the 23rd session of Higher Anatomy, a lecture series for the first year BMS students. The exclusive sessions will be taken up by the eminent speakers of anatomy across the country for a period of 27 days, which started from 23rd of June and will be running up to 20th of July. Before starting the session, let me introduce you to Jignyasa. Jignyasa is a pan-India platform of high fraternity led by the student community of Bharata and was initiated by ABVP in the year 1998. Its motto is Learn Ayush to Practice Ayush. It involves empowering Ayush students from campus to community, bridging the gap between Ayush students and policymakers as well as administrative authorities, connecting every aspect of Ayush, including students, academicians, practitioners, scientists, industrialists, and hospitals, all under one umbrella. Think globally, act locally. In last 2 decades, our efforts were to strengthen the Ayush education system and boost confidence among Ayush students. Jignyasa initiated various programs in different parts of the country, from grassroots to international platforms, through discussions, study circles, seminars, workshops, and conferences. Let me list a few initiatives undertaken by Jignyasa, starting with study circles, lecture series on specific topics, free medical camps, social health status survey, hands-on training workshops, conferences to explore and learn unique aspects of Ayurveda, interaction with eminent Vaidyas and academicians, brainstorming sessions with high stalwarts, policymakers, and key stakeholders of Ayush systems, National Arogya Expo and International Conference, national level seminars, medicinal plant visits, pharmaceutical visits, agitations for the demands of high students community, private internship program for interested students to learn with acharyas, interaction with traditional leaders and visits to explore regional flora, online mock test, social awareness campaigns on various issues, campaigns for the promotions of various concepts of high system like Swarna Bindu Prashana Camp, Ashtoshatottari Yoga, Surya Namaskara and yoga competitions, other etc. Free healthcare assistance to people through local governing bodies during natural calamities and accidents were also provided by Jignyasa. In our yesterday session, more than 600 students joined for the live session and asked their queries regarding the subject and examination. And so far, we are proud to say that we have received more than 15,000 views on our YouTube channel for the sessions of higher anatomy. Vidya Namanarasya Rupamadikam Prachana Guptam Dhanam. We have seen the inability of a common student to afford huge amounts on commercial study platforms, despite their jignasa, the burning desire to learn. Jignasa is here to give a helping hand. Learn anatomy with experts, and all we need is your immense interest to learn. Today, we have Dr. Nitin Kumar Sir, BMS MD, PhD, Associate Professor Rachna Sharira, SDM College of Ayurveda Udupi. Sir completed his UG from L.N. Rao Ayurvedic Medical College, Kappa, and PG from SDM College of Ayurveda, Udupi. Sir has also done PhD from the same college, that is SDM College of Ayurveda, Udupi. Sir has published 30 articles and journals. Sir has attended 77 national and international webinars. Sir is a human resource development literary research organized by ARMARC Koppa in collaboration with Dr. Michel Weiss, Institute of Tropical Medicine, Switzerland. Sir has research dissertation carried out for the degree of PhD in Sharira Rachana entitled A Critical Analysis of the Sharira Rachana Terminologies in Sushruta Samhita. Sir has guided 7 PG dissertations and co-guided 11 PG dissertations. Sir has received Dr. D. Virendra Hegde Pattabhishek Award 2009 by SDM Educational Society Ujjire. Sir has also got Young Teacher Award 2013 by ISRI Karnataka branch. Sir has got Sir has got Pratibha Puraskar in 2021 for awarding PhD by Sri Guru Prashakti Mata Marakada and Sri Prashakti Kshetra Madhyar. Sir, we are glad to have you on the session today, sir, and we welcome you to the session. And to each and everyone who is watching this, hope you find this helpful. Sir, now I request you to carry forward with the session.
Thank you. So, good evening, all. So, today we are going to discuss about the topic urinary system, which is a portion dealt in the paper 2. And the marks allotted for this point or the theme is 10 marks. And if you see the question paper pattern, the urinary system, they consider it as theme E, and theme D is respiratory system, theme E is urinary system. So they asked question from both theme D and theme E. So the question may be asked from theme D or team E. Like that, they divided the marks there. So the three questions can be asked from team D bar E in 5 marks, and 5 MCQs can be asked from team D bar E. So if they ask two questions from respiratory system, you may expect one 5 marks question from urinary system. Or if they ask one question in respiratory system, 5 marks, you may expect a two 5 marks question from urinary system. So like this, because three questions should be asked from respiratory system as well as urinary system for 5 marks. Similarly, in MCQ, if you see, so 5 questions can be asked from respiratory system as well as urinary system. They may ask three questions from respiratory system and two questions from urinary system, or they may ask two questions from respiratory system and three from the urinary system. And you may expect one nice to know type of questions from the urinary system. If you go through the syllabus point, so the congenital anomalies of the urinary system related points is the nice to know point in the urinary system. The congenital anomalies of urinary system, it is a nice to know type of portion. You may expect one nice to know type of question from this urinary system. It may be related with any of the congenital anomaly. So like hypospadias is a congenital anomaly of dash. So like this, or they may ask congenital anomaly of urethra is dash. They may give four options. You have to select the correct answer. So such type of nice to know type of one MCQ question you may expect in urinary system. So if you see the urinary system, it includes mainly four parts. One is kidney, ureter, bladder, and urethra. So kidney, ureter, bladder, and urethra. So we are going to discuss about these four parts one by one. And before discussing about the urinary system, two more points you should know: what is urination and what is micturition. So urination is actually the process of elimination of the urine from kidney, either with or without the involvement of bladder. So excretion of urine or elimination of the urine from the kidney with or without the involvement of bladder. With means there may be storage of urine in the bladder for few hours, then it will be eliminated, or without, it may be directly eliminated out without storing. So that is called as urination. And micturition is actually the process of excretion of the urine from the bladder through the urethra. That is micturition. That is the difference between urination and the micturition. That's why the ureter, the word ureter came for the tube which carrying the urine from the kidney to the bladder. So we'll discuss about each part one by one, starting with the kidney. So it is a pair of excretory organs situated on the posterior wall on either side of the vertebral column and behind the peritoneum. That's why kidney is a retroperitoneal organ. And the main function, if you see, it is removal of waste products. Similarly, it removes the excess water, salts from the blood and maintain the pH. Coming to its location, it is located mainly in the epigastric, umbilical, right and left hypochondriac, and the right and left lumbar region, that is right and left side, depending on the side which it belongs. Similarly, the extent, if you see, it is extending from the upper border of the 12th thoracic vertebra till the middle of the third lumbar vertebrae. And the left kidney is little nearer to the median plane than the right, and the right kidney is slightly lower level than that of the left because of the presence of liver. So if you see the relations, or the height which is above and which is lower, so the transpyloric plane passes through the upper part of the hilus of the right kidney and passes through the lower part of the hilus of the left kidney. So you can see here, this is actually the right kidney which is slightly below, and this is the left kidney which is slightly above. So the hilus, the transpyloric plane will passes through the upper part of the hilus of the right kidney and lower part of the hilus of the left kidney. So this is how it is situated in the posterior abdominal wall. And size, shape, weight, and orientation, if you see, the length is 11 centimeter, breadth is 6 centimeter, and thickness is 3 centimeter. And the left kidney is slightly longer than the right kidney. The measurements: male it is 150 grams, female it is 135 grams, and the color of the kidney is reddish brown. Coming to the long axis of the kidney, the long axis is actually the line or the axis which is passing from the upper pole to the lower pole. So that long axis is directed downwards and laterally, and the upper pole is nearer to the median plane than the lower pole. So the upper pole, this is upper pole which is directed towards the median plane. Lower pole is away from the median pole. Then the transverse axis is from medial border to the lateral border. If you pass an axis from medial border to the lateral border, that is a transverse axis, which is directed laterally and backwards because it is situated on either side of the vertebral column in an oblique manner. So that's why transverse axis is directed backwards and laterally. Coming to the external feature, the shape of the kidney is bean shaped and it has got two poles, upper pole and the lower pole, two borders, lateral border and the medial border, and two surface, anterior surface and the posterior surface. So the upper pole is broad and it is in relation with the suprarenal gland, and the lower pole it is pointed. Then coming to the surfaces, normally the anterior surface is irregular because it is related with many organs, and the posterior surface is flat. Even though anterior surface is irregular, many a times it is difficult to recognize these surfaces just by seeing the irregularity or flatness. So we will differentiate which the anterior surface from the posterior surface mainly based on the arrangement of the structures in the hilum. So that we will discuss later how the structures are arranged in the hilum. Coming to the lateral border, which is convex, whereas the medial border is concave and it contains a sinus or the hilum in the medial border, in the middle part. Coming to the hilum, so hilum, in the hilum we can see many structures, important structures which are arranged from front to back. So those are renal vein. Anteriorly it is a renal vein. Behind that it is a renal artery, and behind that it is the renal pelvis or the upper part of the ureter. So this is how the structures are arranged. Based on these arrangement only, we are going to decide which is the anterior surface. The surface which is close to the renal vein will be the anterior surface. The surface which is close to the ureter will be the posterior surface. Coming to the relations, so whenever you are writing the relations, you should write mainly two relations related with all the abdominal organs. One is the peritoneal relation, second one is a visceral relation. So as I discussed previously, kidney is situated behind the peritoneum in the posterior abdominal wall. That's why it is a retroperitoneal organ. Only the few parts of the anterior surface are covered by the peritoneum, because some of the parts of the anterior surface are directly related with the organs. Some of them are only covered by the peritoneum. Some areas only covered by the peritoneum. That we'll discuss in the relations. Then visceral relations. The upper pole of each kidney is related with the corresponding suprarenal gland. The lower pole is situated about 2.5 centimeter or 1 inch above the iliac crest. Upper pole is related with the suprarenal gland. And the medial border is related with the suprarenal gland above the hilus and ureter below the hilus. It is related with the suprarenal gland above the hilus and to the ureter below the hilus. These are the common relations. Then similarly, there is a common relation in the posterior aspect also. The common relations for both right and left kidney are the diaphragm, medial and the lateral arcuate ligaments, psoas major, quadratus lumborum, and the transverse abdominis, subcostal vessels and nerves, iliohypogastric, and the ilioinguinal nerves. These are the common relations for both right and left kidney posteriorly. In the right kidney, so along with the other relations, there is a 12th rib, and in the left kidney, both 11th and 12th ribs are related with the posterior aspect of left kidney. Next, coming to the anterior relations. Anterior relations are varying from right kidney to the left. So the anterior relation of the right kidney is right suprarenal gland, then the hepatic area or it is related with the liver, then the second part of the duodenal relation, and the colic area. Colic area is related with the hepatic flexure of the colon, and the small intestinal area or the jejunal area. Among this, the hepatic area and the intestinal area are covered by the peritoneum. So only the hepatic area and the intestinal area are covered by the peritoneum. Remaining areas are directly related with the organs. Then lateral border of the right kidney is related with the right lobe of the ureter as well as the hepatic flexure of the right colic flexure. Coming to the left kidney anterior relations, it is related with the left suprarenal gland, stomach, then the spleen, pancreas, body of the pancreas, then the jejunal area, as well as the left colic flexure or the splenic flexure region. So among these, the splenic area, stomach area, and the jejunal area. Splenic area, then the gastric area, and the jejunal area. So these three areas, splenic, gastric, and the jejunal areas, are covered by the peritoneum. The remaining areas are directly related with the organs. Lateral border of the left kidney is related with the spleen on the descending column. Coming to the coverings or the capsule of the kidney. So there are four coverings from inside to outside. They are fibrous capsule, perirenal or the perinephric pad of fat, renal fascia, and the pararenal pad of fat. Fibrous capsule, so you can see this is the kidney. This green line, whatever you are observing, this is actually the fibrous capsule which is closely attached to the outer aspect of the kidney. We can easily remove this fibrous capsule from the kidney. Next is the perirenal pad of fat or the perinephric fat. It is actually the adipose tissue which is seen especially in the borders. Close to the borders, we observe lot of perinephric or the perirenal pad of fat. So whatever you are observing here, this perirenal or the perinephric fat is more abundantly seen along the medial and the lateral border. Outside this perinephric fat, we observe the renal fascia. This renal fascia mainly contains two layers. One is the anterior layer and the posterior layer. Anterior layer is called as fascia carota, present in front of the kidney. Fascia Zucker candle, it is situated behind the kidney. So this is actually the renal fascia, which contains anterior and the posterior layers. And behind this renal fascia or outside the renal fascia, we observe another set of adipose tissue or the fat, which we call as pararenal or the paranephric fat, which is more commonly seen or more abundantly seen along the posterior aspect as well as along the lower pole. So in the posterior aspect of the kidney as well as in the lower pole of the kidney, we observe abundant paranephric fat. Coming to the structure of the kidney, if you see the coronal section of the kidney, so in naked eye we can observe cortex, so outer cortex, inner medulla, and a sinus where we observe the various vessels and the pelvis of the ureter. So cortex, then it is actually the medulla, and the sinus region. It is a space where blood vessels, renal vessels, and the renal pelvis is situated. So this medulla mainly contains about 10 to about 10 conical masses called as renal pyramids. So these are the conical masses called as renal pyramids. They are present in the medulla. The apices or the apex of these renal pyramids are forming the renal papillae, which are opening into the minor calyx. You can see here these are the renal papillae which are opening into the minor calyces. Coming to the cortex, the portion of the cortex which is situated above the pyramid, bases of the pyramid are called as cortical arches, and the portion of the cortex seen in between the adjacent pyramid is called as renal columns. So these are the renal columns seen between adjacent pyramids, and this is the cortex seen above the renal pyramid, which is called as cortical arches. Then each pyramid along with the overlying cortical arch will be called as lobe of the kidney. The pyramid along with the cortex seen above it together forms a lobe of a kidney. Coming to the renal sinus, the third part, cortex, medulla, and the renal sinus. The space which is seen between the hilum to the interior of the kidney, that is towards the renal pyramid, will be called as the renal sinus, which mainly contains the branches of the renal artery, tributaries of the renal vein, and the renal pelvis. And in this renal sinus region, the renal pelvis, it is actually the starting part of the ureter, renal pelvis. Here this renal pelvis will be divided into two to three major calyces. You can see here this is the renal pelvis, which is mainly dividing into two to three. These are major calyces, whatever you are observing these branches, and each these major calyces in turn divided into 7 to 13 minor calyces. So these are the minor calyces present in the is the further divisions of the major calyces forming these minor calyces, and in this minor calyces only the renal papilla, which is actually the apex portion of the renal pyramids, opens. Then coming to the histology, if you see the kidney, which contains mainly 1 to 3 millions of uriniferous tubules, this uriniferous tubule contains two parts. One is the secretory part, whatever you are observing, this is the secretory part, and the collecting part. The secretory part is actually the nephron. So I think we already studied about the nephron even in the physiology. So nephron is actually the structural and functional unit of the kidney. So which is actually forming the secretory part, which contains glomerulus, Bowman's capsule, proximal convoluted tubule, then the descending limb of Henle, loop of Henle, ascending limb of Henle, then distal convoluted tubule, and finally it is junctional tubules which are opening into the collecting tubule. Collecting tubule is a separate part. And this secretory part or the nephron is opening into the collecting tubules. Many such tubules together forms the ducts of Bellini. That ducts of Bellini is opening into the minor calyces at the renal papilla or at the apex of the renal pyramids. So this is how the urine from the nephron reaches the collecting tubule, and from the collecting tubule forms the ducts of Bellini, and from the ducts of Bellini it is entering into the minor calyces. From minor calyces later it reaches the major calyces, and it will enter into the renal pelvis. Coming to the blood supply, so the kidney is supplied by the renal artery. Each renal artery will be mainly divided into anterior and posterior division near the hilum. That each these divisions further divide into segmental arteries. So there are mainly 5 segmental arteries in each kidney, and these segmental arteries will be further divided into interlobar arteries, which runs in between the adjacent pyramids. So those interlobar arteries forms a arcuate artery near the base of the pyramid, and from the arcuate artery, interlobular artery will be arising. So this is the arterial supply. And venous drainage. So these interlobular veins will be draining into arcuate veins. From the arcuate vein, interlobar veins will collect, and these interlobar veins will be finally draining into renal veins. Then coming to the lymphatic drainage, it is by the lateral aortic nodes, those nodes which are present on either side of the aorta. The nerve supply, the sympathetic is from T10 to L1, whereas parasympathetic is from the vagus. They together forms the renal plexus near the kidney. So coming to the applied aspects of the kidney, one of the applied anatomy you should remember is whenever you are doing any surgical procedures in the kidney, that is surgical exposure of the kidney, normally 12th rib is resected. So when you are resecting that 12th rib, you should take care of the pleural cavity as well as the pleura, because just in front of the 12th rib only the lower margin of the pleural cavity is present. So whenever you are resecting the 12th rib, there may be a possibility of injury to the pleura also. So that you should take care. Then one more thing related with the kidney is the renal angle. It is the angle between the lower border of 12th rib and the outer border of the erector spinae. On either side of the vertebral column in the posterior aspect, there is a vertical chain of muscle called as erector spinae. So in between the lower border of the 12th rib and the erector spinae muscle, there is an angle. So that angle will be called as renal angle. So I think I'll show in one. Yeah. So this is the 12th rib, and here the erector spinae muscle will come. So the angle between the 12th rib and the erector spinae, this region is actually the uh, renal angle region. So normally tenderness will be felt in this region when you apply pressure over the angle. Tenderness will be felt. So now coming to the another congenital pathology related with the kidney is the polycystic kidney. So it is actually the non-union of the secretory and the collecting part. As you know, secretory part is nephron, collecting part is collecting tubules. If there is no connection between the secretory part and the collecting part, then such condition will be called as polycystic kidney. This is one of the congenital condition of the kidney. So these are some of the possible questions may be asked for nice to know. So congenital condition of the kidney. So they will give four options. One of the option is polycystic kidney. So it will the kidney appears like this. So next is actually the horseshoe kidney, another deformity where the lower end of the or the lower poles of the both the kidneys will be fused. Sometimes upper poles are fused, and ureter will pass in front of the isthmus fused part. So this is actually the horseshoe kidney where the lower poles of the right and left kidney are fused and ureter is passing in front. Sometimes instead of lower pole, the upper poles of the right and left kidney may unite. So this is related with the some of the applied aspects of the kidney. Another thing is the pelvic position of the kidney. Normally during development, kidney will be in the pelvis region. So even after the complete development, if the kidney is not shifted to the abdominal region, then we still observe pelvic position of the kidney. Then second one is another applied aspect is the unilateral aplasia. That is a poor development of the kidney. Aplasia or the hypoplasia of the kidney may occur, and sometimes instead of two sides, both the kidneys may be observed in one side also. So these are some of the this is related with the kidney, and related with the kidney you may expect some questions like relations of the kidney for 5 marks. So this is one of the probable questions for 5 marks in the kidney, that is the kidney part of the urinary system. Similarly, some congenital pathology related with the kidney may be asked for MCQ question, or they may ask the measurements, the length of the kidney is dash, so or the weight of the kidney in male or the weight of the kidney in female. So such type of questions you may expect it for MCQ. So this is related with the kidney. The next is actually the ureter. It is actually a pair of narrow, thick-walled muscular tubes which convey urine from kidney to the urinary bladder. They lie deep to the peritoneum, so they are also retroperitoneal organs. In that, half portion will be seen in the abdominal region, half part will be seen in the pelvic wall. Coming to the length, it is 10 inch or the 25 centimeter long. In that, 5 inch in the abdomen, 5 inch in the pelvis, and the diameter of this ureter is 3 mm, and it may show five constrictions. So we'll see which are those constrictions one by one in the further slides. So coming to the brief course of this ureter, as I discussed previously, this ureter starts in the renal sinus, the space near the hilum. It starts in the renal sinus as a funnel shaped dilatation called as renal pelvis. Then that renal pelvis will run along the medial margin of the kidney till the lower pole. So at the lower pole, it becomes ureter proper. That ureter proper, first it runs downwards and slightly medially on the psoas major muscle in the abdominal region, and it will enter into the pelvis by crossing the terminal part of the common iliac artery. The common iliac artery will divide into external and internal iliac artery. Near that termination, so this ureter will enter into the pelvis. And in the true pelvis, so whatever you are observing here, so till here it is actually the abdominal part, then it is actually the region which is seen in the pelvis part. In the true pelvis, first it runs downwards and backwards and laterally along the anterior margin of the greater sciatic notch. So you can see here it runs downwards, backwards, and laterally along the anterior margin of the greater sciatic notch in the upper part of the true pelvis. Then at the ischial spine, it runs forwards and medially and reaches the base of the urinary bladder and finally opens into the trigone of the bladder. Coming to the constrictions, there are five constrictions. One is at the pelviureteric junction, that is at the lower pole of the kidney. Second, at the brim of the lesser pelvis, where the ureter enters into the pelvis from the abdomen. The third part is the place where it is crossed by the ductus deferens in case of male, or broad ligament of uterus in case of females. And the fourth constriction, it is at the region where it is entering into the bladder wall. And the fifth one is at the lateral angle of the trigone, where it enters into the inner aspect of the bladder. So you can see here, this is the pelvic junction. Then it is the place where pelvic brim, that is where it is entering into the pelvis. Third is at the region where it is crossed by the vas deferens or the ductus deferens. Four, at the region where it joins or enters into the bladder. And the fifth one where it is entering into the inner aspect of bladder, that is at the angle of the trigone. Next, coming to the relations. So in the pelvis, renal pelvis region, the renal vessels are present in front and behind. The branches of the renal vessels will be seen both in front and behind the renal pelvis. Then outside the kidney, so the anterior relations, in the right side it is the renal vessels and the second part of the duodenum. The renal vessels and the second part, this is the second part of the duodenum, it will be seen in front. Whereas in the left side, it is the renal vessels, pancreas, peritoneum, and the jejunum. The renal vessels, pancreas, peritoneum, and the coils of the jejunum, they will be seen in front in the abdominal part, that is outside the kidney. And posteriorly, it is the psoas major muscle. As you know, the ureter is passing over the psoas major. Then the remaining part, that is below the ureter proper, that is below the lower pole of the kidney. So if you see the relations of the ureter in the right side, anteriorly, it is the third part of the duodenum, peritoneum, the right colic and ileocolic vessels which are supplying the ascending colon and the part of the transverse colon. Then the gonadal vessels, root of the mesentery, and the terminal part of the ileum. So this region. In this region, it is related with the peritoneum, gonadal vessels, then the branches of supplying the ascending colon, as well as the cecum region. So those are actually crossing the or present in front of the abdominal part of the ureter in case of right side. In the left side, it is almost similar, where it is the peritoneum, gonadal artery, left colic vessels, sigmoid colon and the sigmoid mesocolon are seen in the left side in this region. Coming to the posterior ureter is common psoas major. You can easily remember the psoas major throughout in the abdominal part. Along with that, it is the tips of the transverse process of the lumbar vertebra. Then it is actually the medial relation. If you see in the right side, it is the inferior vena cava, and in the left side, it is the inferior mesenteric vein and the left gonadal vein. So in the right side, it is the inferior vena cava. In the left side, it will be the inferior mesenteric vein. As well, you can see this is the inferior mesenteric vein, and the left gonadal vein will be seen medial to the ureter in the left side. Then coming to the pelvic part of the ureter, as I discussed previously, initially it will run downwards, backwards, and laterally, uh, and finally it will runs forwards and medially. So in the first downward, backward, and lateral course, posteriorly it is related with the internal iliac vessels. It is related with the internal iliac vessels, both artery and the vein, and the lumbosacral trunk and the sacroiliac joint. In this region, so it will be related with the internal iliac vessels, as well as the sacroiliac joints and the lumbosacral trunk, which is a junction between the lumbar plexus and the sacral plexus. Then in the lateral side, so lateral side means related with the bone. So it is related with the obturator fascia, which is covering the obturator foramen. Similarly, obturator vessels and the nerve. So this region. So this is actually the obturator foramen region. Here it is related with the obturator fascia, as well as the obturator vessels and nerve. mainly in case of male, and in case of female, so even it is related with the, or it forms the posterior boundary of the ovarian fossa where the ovary is situated. Coming to the forward course, so where it is running forwards and medially to reach the bladder. So this is the forward course in this region where it is reaching towards the bladder. So in this region, so it is related with the ductus deferens. The ductus deferens will cross this ureter from lateral to medial side. You can see here the ductus deferens is crossing from lateral side to medial side above the ureter. Then even it is related with the seminal vesicle which is present below. You can see seminal vesicle is situated below it. So in case of females, it is situated at the lateral side of the broad ligament of the uterus. So then it will reaches the anterior part of the vagina. In the upper part, it will be situated the inferolateral part of the, sorry, inferomedial part of the broad ligament of the uterus. So in this region, you can see the infero-medial part of the broad ligament of the uterus, it will be seen, and finally it will run in front of the vagina. So that is the course in the forward part. Then the intravesical, that is within the wall of the bladder. So it will have a oblique course. Because of that oblique course, the regurgitation of urine from the bladder to the ureter will be prevented, and this ureter will open with a distance of 5 centimeter apart in the distended bladder, whereas 2.5 centimeter apart in the empty bladder. So that is actually the base of the trigone is actually 2.5 centimeter in the empty bladder, and it will be 5 centimeter in the distended bladder. Coming to the blood supply, the upper one third part of the ureter is supplied by the branches of renal artery with the additional supply from gonadal or iliac vessels. And in the middle part, the branches arising from the aorta supplies ureter with some branches from gonadal or the iliac vessels. And the pelvic part of the ureter is supplied by vesicle or the middle rector or the uterine vessels, uterine in case of females. So this is the blood supply. Coming to the nerve supply, it contains a sympathetic and the parasympathetic. Sympathetic supply is by T10 to L1, whereas the parasympathetic supply is from S2 to S4 segment, sacral pelvic splanchnic nerves. Coming to the histology, if you see, so it contains mainly three coats: outer tunica adventitia, connective tissue layer. Deep to it, it is the muscular layer. So this muscular layer in the upper two-third part contains outer circular and the inner longitudinal core, whereas in the lower one-third part, it contains three layers: outer longitudinal, middle circular, and inner longitudinal. And the innermost is the mucous membrane layer, which is lined by a transitional epithelium. This is the specialty, which is also called as uroepithelium. So this type of epithelium is seen only in the urinary system. So ureter, bladder, and all, they contains a transitional epithelium. The specialty of the transitional epithelium, it will not allow the exchange of urine between the tube as well as the blood vessels which are present in the walls. So it will only carry the urine. There will not be any exchange in that region. Coming to the applied anatomy, so one of the applied aspect related with the ureter is actually the renal colic. So it is actually the stone formation in the ureter, so which may cause spasm of the ureter. And in this renal colic, the patient may complain of radiating pain from loin, that is the back region, to the groin region of the inguinal region. So because of the common sympathetic nerve supply to the skin as well as to the ureter. Then second one is the ureteric stone or the renal stones commonly seen or commonly get obstructed in the region of constrictions. Constrictions are the narrowest regions of this ureter. So in those regions, normally they get impacted. And there is one more congenital anomaly related with ureter. It is actually the ureteric bud, which is going to form the ureter in the developing stage. So if it is divided into two, then you may see a complete double ureter or partly bifurcated ureter. So it is because of the congenital anomaly of the ureteric bud, which is going to form the ureter. So in relation to ureter, you may expect 5 marks questions like relations of the ureter or explain ureter with its blood supply, nerve supply. So similarly, you may expect some MCQ type of questions also related with the ureter regarding the length of the ureter. Uh, so that is some of the possible questions you may expect in the ureter. Now coming to the next point in the urinary system is the urinary bladder. So this urinary bladder, it is a muscular reservoir which temporarily store the urine, which is seen in the anterior part of the pelvic cavity. If you see the size and shape, so the size, shape, position of the urinary bladder will vary depending on the amount of the urine it contains. So when it is empty, it is tetrahedral in shape. Then when it is empty, it will be seen within the pelvis, and when it is filled with the urine, it may even extend it into the abdominal cavity towards the umbilicus or even higher. Capacity, if you see, it is around 220 ml on an average, varying from 120 to 320 ml. And filling beyond 220 ml may cause desire to micturate, and filling up to 500 ml may be tolerated. Beyond it may produce painful condition, or it may cause referred pain in the lower part of the abdominal wall. Coming to the external features, as I told, empty bladder is tetrahedral in shape, four-sided, which contains apex, which is directed forwards. This is the apex, which is directed forwards, base, which is directed backwards, then the neck, which is directed downwards, and it contains three surface: superior surface, right and left inferolateral surface, and it contains four borders: anterior border which separates inferolateral surface of right and left side, then the lateral borders which separate the superior surface from inferolateral surface. There are two lateral borders, and one posterior border which separates superior surface from the base. So these are actually the external features of the empty bladder. In the full bladder, it is oval shape, which contains an apex, which is directed towards the umbilicus, the neck, which will be directed downwards, similar to the empty bladder. And in the full bladder, we observe only two surface: anterior surface, which is directed towards the abdominal wall; posterior surface, which is facing backward. Coming to the relations, the apex, which is connected with the umbilicus with the help of median umbilical ligament, which is called as obliterated urachus. So whatever you are observing, this is the urachus, which is connecting the apex with the umbilicus. Then the base, which is in case of female, it is related with the uterine cervix as well as the vagina. That is actually the portion which is facing backward. This part, the posterior part, which is related with the uterine cervix and the vagina in case of female, and in case of male, so upper part of the base is covered by the peritoneum, and that peritoneum is forming a pouch called as rectovesical pouch. It is actually a pouch, or the pouch between the rectum and the bladder, which contains coils of intestine. The lower part is devoid of peritoneum, and it is directly related with the seminal vesicles as well as the vas deferens or the ductus deferens. This is the lower part, which is directly related with the seminal vesicle and the ductus deferens. And this upper part, which is covered by the peritoneum. And the triangular area between the right and left ductus deferens is actually covered by the fascia of, or the rectovesical fascia of the denominus. Coming to the neck, which is the lowest and the fixed part, and it is situated about 3 to 4 centimeter behind the lower part of the pubic symphysis, but situated above the pelvic outlet. And it is pierced by the internal urethral orifice and covered by a sphincter called a sphincter urethrae. Sphincter vesicae. In case of females, it is surrounded by the pelvis, and in males, it is related with the prostate gland. So in infants, the neck is situated at the upper border of the pubic symphysis, whereas in the adult it is situated at the lower part of the pubic symphysis. Coming to the superior surface, so this is the superior surface. The superior surface, in case of male, it is completely covered by the peritoneum and related with the sigmoid colon and the coils of terminal ileum, or the coils of the ileum. So this is superior surface covered by the peritoneum related with the sigmoid colon and the coils of the ileum. That is both in male and female. In case of female, so we may observe peritoneum, it is not covering fully here. The greater portion of the superior surface will be covered by the peritoneum, except a small area close to the posterior border. You can see, so the small posterior part of the superior surface is devoid of peritoneum. The remaining portions are covered by the peritoneum. And the pouch which is produced by the peritoneum is actually uterovesical, because it is seen between the uterus and the bladder. And the posterior part, which is devoid of peritoneum, is related with the supravaginal part of the cervix. So this portion is related with the supravaginal part of the cervix. Coming to the inferolateral surface, so this is the inferolateral surface on one on either side. They are related to posterior surface of body of the pubis. They are related with the posterior surface of body of the pubis and separated from each other by the anterior border. As I told, they are related with the posterior surface of the pubis. They also related with some of the other structures in that region, like puboprostatic ligament, and then the retropubic pad of fat, levator ani muscle, and the obturator internus muscle. In case of females, instead of puboprostatic ligament, because there is no prostate ligament in females, prostate gland in females, instead of that, so we may observe pubovesical ligament. The remaining all, it is same even in the females. Then when the bladder is filled with the urine, the inferolateral surface will be converted from or converted to become anterior surface. That anterior surface is devoid of peritoneum, or it is not covered by the peritoneum in major part, except in the upper part, which is covered by the peritoneum. That lower non-peritoneal part of that distended bladder is directly in contact with the anterior abdominal wall, and this is the region where normally we do the surgical procedure, or we will enter into the bladder. Then coming to the ligaments, there are many ligaments related with the bladder which are supporting the bladder. So the true ligament, which are actually condensation of the deep fascia of the pelvis region. So some of the peritoneal ligaments also there, or the peritoneal folds are also there, which we call it as false ligament. The true ligaments are lateral true ligament, lateral and the medial puboprostatic ligament. Instead of puboprostatic in case of female, pubovesical ligament. So you can see the medial and the lateral puboprostatic ligament, lateral ligament, and the posterior ligament. So these are the true ligaments, and there are false ligaments also. So medial umbilical fold, lateral false ligament, and the posterior false ligament. These are the false ligaments which are produced by the peritoneal folds. Now coming to the interior of the bladder, if you see, in the empty bladder, the greater part of the mucosa will show irregular folds because of the loose attachment of the mucous membrane to the muscular coat. But a small triangular area at the lower part of the base, where the mucosa is firmly attached to the underlying muscular coat. The muscle coat of the bladder will be called detrusor muscle. So that the area where the mucosa is firmly attached to the muscular coat will be called as trigone. So you can say this is actually the trigonal region where the mucous membrane is firmly attached to the muscular coat. In other places, this mucosa is loosely attached to the muscular coat. So that apex of the trigone, it is directed downwards, and there we observe the opening of internal urethral orifice. And the base, which is directed above, On the angle at the posterolateral angles of the base of the trigone, we observe the opening of ureter. So this is actually the base of the trigone. At the angles of that base, we observe the opening of ureter, and at the apex, we observe the opening of internal urethral orifice. There is a slight elevation just behind the urethral orifice. That elevation, whatever you are observing here, the slight elevation near the apex or the apex of the trigone or the internal urethral orifice is uvula vesicae. That uvula vesicae is actually produced because of the presence of medial lobe behind that. So medial lobe of the prostate is present behind that apex of the trigone. So that is producing a surface elevation inside the bladder, that we call it as uvula vesicae. Then the base, as I told, that base is produced by the continuation of the longitudinal muscle coat of the right and left ureters. So the longitudinal muscle coat of the right and left ureters continues and forms the base of this trigone. Coming to the arterial supply, so this bladder is supplied by both superior and inferior vesical artery, with some additional supply from the obturator inferior gluteal arteries. And in case of female, even it is supplied by uterine and vaginal arteries instead of inferior vesicle. Superior vesicle will be seen. Along with the superior, it may be additionally supplied by uterine and the vaginal arteries in the lower part. Venous drainage is by the vesical plexus of veins which are seen on the sides of that is inferolateral aspect of the bladder. And the lymphatic drainage is into the external iliac nodes with some additional drainage into other nearby nodes. Coming to the nerve supply, sympathetic supply is by T11 to T11 to L2, whereas parasympathetic supply is by S2 to S4, and somatic supply is by the pudendal nerve, which is supplying the sphincter urethra. Coming to the applied anatomy of this bladder, one of the applied anatomy is distended bladder may be ruptured by any injuries into the lower part of the abdomen. If there is a direct injury to the lower part of the abdominal wall, it may damage the distended bladder. Then the cystoscopy is a scopy we are using. We are studying the interior of the bladder. To visualize the interior of the bladder, we are doing this procedure. With the help of cystoscope, we are seeing the interior. Then coming to the chronic obstruction to the outflow of the urine may be produced because of enlarged prostate. As I told, uvula vesicae, it is a surface elevation. If that uvula vesicae is enlarged too much, it may obstruct the internal urethral orifice. So that is one of the condition. Second one, another applied aspect is urinary incontinence. Whenever there is an injury to the cervical or the thoracic segments of the spinal cord, so the muscles of the bladder may be relaxed. The sphincter vesicae, which is a sphincter seen around the uh, internal urethral orifice, will be contracted, but the sphincter urethra, which is seen in the membranous portion of the urethra, will be relaxed. So because of that, so we may observe a condition called as automatic reflex bladder, where there may be slightly dribbling of the urine will be seen. Next is actually the condition is ectopic vesicae. It is a congenital formation where the anterior abdominal wall along with the anterior wall of the urinary bladder is not developed fully. So the interior of the bladder will be exposed to the external environment. So this is a condition called as ectopic vesicae. So these are some of the applied aspects related with the bladder. So in bladder, you may expect the relations of the bladder. Similarly, you may expect the question related with the capacity of the bladder. What is the maximum amount of urine collected in bladder? Or you may expect questions like a congenital anomaly of the bladder, ectopic vesicae, whatever I told. So these are some of the questions. You may expect one 5 marks question like relations of the bladder or explain bladder in detail for 5 marks. and you may expect some MCQ type of questions like the capacity of the bladder, or it may be related with some congenital anomaly. That is a nice to know type of questions here. Next is about the last point in the urinary system is the male urethra. So there is slight difference between male urethra and the female urethra. So the length and the relations, we'll discuss about it. So male urethra, it is a membranous canal for the external discharge of urine and the seminal fluid, and it is 18 to 20 centimeter long. And in case of flat state of the penis, it is S-shaped, whereas in erect state, this male urethra will be J-shaped. And coming to the extent, it is extending from the internal urethral orifice present at the apex or the neck of the bladder till the external urethral orifice which is present in the glans penis. So coming to the parts, mainly it contains three parts: prostatic part, membranous part, and the spongy part. Prostatic part is 3 centimeter long, seen within the prostate, whereas the membranous part it is 1.5 to 2 centimeters, seen within the sphincter urethrae. That is a sphincter which is present around the membranous part. And the last part, which is the longest part of the urethra, it is the spongy part, seen within the bulb as well as the corpus spongiosum of the penis, which is 15 centimeter long. So this is the prostatic part, this is the membranous part, and this is the spongy or the penile part of the urethra. So coming to the prostatic part, so it starts near the internal urethral orifice, then runs vertically downwards through the prostate, and it is the most widest and most dilatable part of the male urethra, and it is more wide in the middle part compared to the other regions of the prostatic part, and it is narrowest at the junction with the membranous part. So in the posterior wall of the prostatic part of the urethra, we observe some features like there is a median longitudinal ridge called as urethral crest. So this is the median longitudinal crest or the ridge. We call it as urethral crest, which is seen in the posterior wall. In the urethral crest, there is an elevation called as colliculus seminalis. This is the elevation which is called as colliculus seminalis, seen in the urethral crest. And in that colliculus seminalis, there is a slit-like opening for the prostatic utricle in the midline, and on either side of that prostatic utricle orifice, we observe the opening of ejaculatory duct, which is produced by the union of seminal vesicle and the ductus deferens. Then the prostatic sinus, a groove which is seen on either side of the urethral crest. This is the urethral crest. On either side of the urethral crest, there is a groove. That groove will be called as prostatic sinus, where prostatic glands, around 20 to 30 prostatic glands, will be opening there. Then what is prostatic utricle? As I told, this prostatic utricle is opening into the middle of the urethral crest. That prostatic utricle is just a blind sac of 6 mm, which is seen between the median and the posterior lobes of the prostate, which is actually homologous with the uterus of the vagina in case of females. Coming to the membranous part, which is actually the narrowest or least dilatable part of the urethra, except urethral orifice. That is, external urethral orifice is the very narrowest part. Next to the external urethral orifice, it is actually the membranous urethra, which is the narrowest area. And it is piercing the perineal membrane about 2.5 centimeter below and behind the pubic symphysis. And this part is surrounded by the sphincter urethra or the external urethral sphincter. And surrounding to this membranous part, we observe the bulbourethral gland of Cowper. Even though it is situated on either side of the membranous part, it will not open into the urethra in this region. Instead, it will open into the spongy part of the urethra. This gland will open into the spongy part of the urethra. So many small urethral glands also opens into this membranous urethra. So this is actually the membranous urethra, which is covered or is surrounded by the sphincter urethra. So on either side of the membranous urethra, we observe the bulbourethral glands, which are opening into the. You can see this is how it is entering into the spongy part. This duct is opening in the spongy part of the urethra. The last part is the spongy or the penile part, which is actually running forwards and upwards, first in the bulb of the penis, then it runs vertically downwards uh, in the corpus spongiosum, and finally end in the external urethral orifice at the tip of the glans penis. So this is actually the part which is seen in the bulb, and then it is seen in the corpus cavernosus. Sorry, corpus spongiosum. Then the diameter of the penile part or the spongy part of the urethra is 6 mm, and it will show some dilatations. One at the starting part of the penile urethra that we call as intrabulbar fossa. This is the intrabulbar fossa. Second dilatation which you see at the glans penis, it is the navicular fossa. So then the external urethral orifice, it is the terminal part of the spongy urethra, so which is about 6 mm in measurement, and then the ducts of the bulbourethral gland will open into the spongy part about 2.5 centimeter below the perineal membrane. So you know this is the perineal membrane seen below the sphincter urethra. So just about 2.5 centimeter below it, you can see the opening of the bulbourethral gland into the spongy part. So other than the opening of the bulbourethral gland, even many urethral glands of litter, as well as small recesses called as moragagni, also opens into the penile part. You can see those small glands of the litter are opening into the penile part at different regions. Then, in relation to the urethra, we observe mainly two sphincters. One is the internal urethral sphincter, which is also called a sphincter vesicle, which is seen around the neck of the bladder, which is involuntary in function, which is controlling the neck of the bladder as well as prostatic part of the urethra, which is made up of smooth muscles along with that elastic and the collagen fibers supplied by the sympathetic nerves. Whereas the external urethral sphincter or the sphincter urethrae, which is actually voluntary in function, which is supplied by the perineal branch of the pudendal nerve, and it is controlling the membranous urethra. That's the middle part of the urethra, and it is made up of striated muscles. Coming to the blood supply, and the lymphatics. The blood supply of the urethra, it is similar to the blood supply of the prostate gland and the penis. They are supplied by the inferior vesicle, middle rectal, and the internal pudendal vessels. And the lymph from the prostatic and the membranous part is draining into internal and the external iliac nodes, whereas from the penile part it is into the deep inguinal lymph nodes. And nerve supply, sympathetic supply is by L1 and L2, parasympathetic is by S2 to S4, that is pelvic splanchnic nerves. Then the female urethra, so the length here it is small. So in case of male it is around 18 centimeter, but in case of female it is 4 centimeter long and 6 mm in diameter. And it begins at the internal urethral orifice, that is at the neck of the bladder only. That is about 5 centimeter behind the pubic symphysis. Then it runs downwards and forwards in front of the vagina, and finally it opens into the external urethral orifice at the vestibule. And if you see the cross section of the female urethra, the shape will vary according to the location. In the upper part, it is crescentic. In the middle part, it is stellate or star shape. And in the lower part, it is transverse slit like. And at the external orifice, it will be in the sagittal slit. So, whatever you are observing, so this is actually the urinary bladder, this is the urethra, which is seen in front of the vagina. So then, if you see the mucosa of the urethra, which is folded and contains many mucosal glands, And the paraurethral glands of skinny are also present on either side of the urethra in case of females. And the urethra in case of female is most dilatable part uh, compared to male. So coming to the blood supply, so the blood supply to the female urethra is by the superior vesicle and the vaginal branches, in the upper part by the superior vesicle, and in the lower part it is supplied by the vaginal artery. The venous drainage is into the vesical venous plexus. Lymphatic drainage it is into the external and internal iliac nodes, and nerve supply is by L1, L2, the sympathetic, parasympathetic it is S2 and S2 to S4 pelvic splanchnic nodes. So coming to the last point, that is applied aspects of the urethra. So one of the condition is the rupture of the urethra. Second is the urethritis, that is the infection of the urethra. So another condition is stricture of the urethra, which may be produced as a complication of infection, untreated infection. And some congenital anomalies also you may expect related with the urethra. One is hypospadias, where urethra opens the undersurface of the penis or the perineum, and epispadias, where urethra opens in the dorsum of the penis. So this urethra related questions, so norm you may not expect much question for 5 marks from female urethra. Male urethra you may expect some 5 marks question. Similarly, you may expect some MCQ type of questions like length of the male urethra or length of the female urethra, or some congenital anomalies like hypospadias or epispadias. So they may ask, dash is a congenital anomaly of the urethra. So they may give four options, and one of the option may be epispadias or hypospadias. So these are some of the probable questions you may expect in the urinary system. I think with this, I'll come to the end of my talk. I once again thank the Jignyasa team for giving me an opportunity. Thank you. Hello. 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 Karthik. Karthik. Karthik.
Hello, sir. Hello, sir.
Karthik.
Yes, sir. Yes, sir. Sir, I got few questions on WhatsApp, sir. I will read it out to you.
Hello, Patel.
Yes, sir. Shall I read it out, sir?
Yeah.
Yeah. Yes, sir. Thank you, sir. Sir, for each of our organ of urinary system, how many relations should we learn? Hello, sir. The question is for each organ of urinary system, how many relations should we remember?
When you are talking
When you
about
are talking about
hello.
hello. Yes, sir. You are audible.
So when you are talking about the relations of kidney or the ureter, you have to talk both peritoneal relation and the visceral relations. So peritoneal relations and the visceral both are equally important. If the question is like explain visceral relation of the kidney or visceral relation of the ureter, then you have to highlight only on visceral relations. If the question is like explain relations of the kidney or the ureter, then we have to explain both peritoneal relations as well as visceral relations. Same with the bladder also. So, along with the peritoneal relations, you have to explain the anterior relations, posterior relations, medial, and the lateral relations. At least you should remember the major important structures. If you forget small vessels, that is okay. But the important organs or the important structures like ductus deferens, or it may be the third part of the duodenum or the second part of the duodenum related with the ureter, or in case of kidney like pancreas, spleen. So those major structures, whatever it is there, you have to remember. Clear?
Yes, sir. Thank you. The next question is related to diagrams, sir. That how many diagrams one should write if kidney or ureter is asked?
So the
So the question,
question like anterior relation of the kidney, then you have to write the diagram for both anterior relation for right kidney and anterior relation of the left kidney. If the question is like relations of the right kidney, then you have to write the relations, anterior relations and posterior relations of the right kidney. The question is only posterior relations of the kidney, so then you have to draw the diagram for posterior relation of the kidney. Otherwise, one diagram to show the anterior relation of the kidney, one diagram to show the posterior relations of the kidney. And in case of ureter, so I think one or two diagrams maximum is enough, related with the one diagram to show the relations with respect to abdominal part, one diagram related to the pelvic part.
Thank you, sir. Um, the next question is it's from us, sir. Like I think I previously asked this question also, but I would like to ask the same question again to you today, sir. The question is, sir, what would you like to suggest for the students of first year who are writing their exams to prepare themselves mentally to face the current upcoming exams bravely and not to go under any mental stress?
So I think already I
So I
have
think
discussed
already.
this point in the last session also, that one is the time management. So because you are writing different pattern question paper this time, and there will be four 10 marks question and eight 5 marks question and 20 MCQ. So I think you may not get more than 25 minutes for each 10 marks question, and you may not get more than 6 minutes for 5 marks question for each 5 marks question. and each MCQ you have to finish within 1 minute. So, and in the end, you may get 10 minutes time for rechecking the answers. That is the one thing. Second thing is just to go through some old question paper where you will get some probable questions related with these topics. Along with that, just to check the themes of each question paper. So from which theme they are going to ask MCQ, from which theme they are going to ask 5 marks question, and from which theme they are going to ask 10 marks question. If you go through those pattern of question paper in each syllabus, so we'll come to know so which are the possible 10 marks question, which are the possible 5 marks question, which are the possible MCQ questions also. Definitely there will be two nice to know type of questions and three desirable to know type of questions, and then the remaining must know type of questions. And a diagram for both the 10 marks and 5 marks is compulsory. Diagram for both 5 marks and 10 marks question is compulsory. And similarly, you should follow the guidelines for writing the answers. That is, for each 10 marks question, 6 pages, and for 5 marks, 3 pages. And the 49th page is for the first 10 MCQ, and the 50th page is for last 10 MCQ. So, with this, I'll.
Thank you, sir. Yes, sir. Yes, sir. Thank you, sir. Thank you for answering the same question once again. We are really grateful for that, sir. I think that is all from our question and answer session, sir. And this is our we are wrapping up the 23rd session of Air Anatomy, and this is your second session, sir. It was really humble of you to take two sessions, sir. Which was for which we are really grateful, and we would like to extend our warmest greetings and our gratitude to you, sir, for helping us and supporting us in a sacred work to help us students, sir. We are really grateful for that, sir, and we are really happy to host you twice in this whole journey. On behalf of my whole team at Jignyasa, I would again like to thank you, sir, from our heart. We would like to express our deepest um, gratitude to you, sir, for agreeing for these multiple sessions, be it taking a long, hour-long sessions and explaining the doubts multiple times. Thank you for that, sir. We are really grateful for you, and in future we would personally like to meet you and work on other things and collaborate for the betterment of high students and to make anatomy as much as fun in a learning way possible, sir. Thank you again, sir.
Thank you.
Thank you, sir. Sir, now I would request your permission to end the session, sir.
Yeah, sure.
Thank you, sir. Thank you so much.